And yeah, to go back what you were saying about too, like there is some lack of understanding of how the fire department runs scenes. Like there's a hierarchy. Everyone has kind of their assigned role versus when you're on an ambulance with you and your partner, the roles kind of change from call to call. You know, you kind of just do it by the seat of your pants. There's not necessarily this huge organized plan going into a call versus if you guys are training a brand new EMT or something, you're forcing them to run the call and stumble through it. And I think the private ambulance comes on scene and they're like, why is this person leading the call? And you're like, we're pushing them out there to try to stumble their way through this so that they get better at it. And then they'll jump all over their case when there's a pause in the conversation or whatever, because they just don't realize we're letting them run this call. I made that mistake a million times. I'd be like, this call's going nowhere. We're like not doing anything. And it's like, well, we're trying to, you know, this patient's not dying. You know, the patient's fine. We're letting them stumble their way through because everybody's got to do it. And so I think that's another misconception too, is you don't know this is a brand new EMT that you haven't seen before. And they're trying to stumble their way through a call just like anybody would.
Yeah, and part of that is communication, though. Part of that is communication on the part of the crew that's doing the training to the crew that's arriving on the scene of, hey, this is going to take a little bit, but just can we go with it unless something is going, you know, if something's going sideways, then we're going to step in.
Right.
But otherwise, can we just kind of roll with it?
It's kind of like when we have a paramedic student in training, right? And we're just like, hey, paramedic student. We're like, oh, okay.
Yeah.
And so we all kind of like step back and wait.
Yeah.
Right?
And when they're in that uniform, it's easier to recognize. I think when they're wearing the same thing as the rest of the fire department, it's harder to recognize maybe.
Or in the paramedic that's, as we would say, blue booking. You know, they're not wearing that student uniform because they're done with that part, but this is now them in the process of getting cleared to function as a paramedic within our system, and having that communication of, hey, this person's blue booking, give them a moment, let them work through the stuff. If anything looks like it's unsafe or whatever, then we'll step in and we'll correct the course.
One scenario I always hated on the ambulance was being first on scene because it just didn't happen that often. So we were really bad at it. And like you're getting on scene, you're like, oh no. They're like, I don't even see them anywhere. Like I got to go in there and be the one to talk. And like, and like the organization of a call, I think was less clear to me because, you know, you go in, you talk to the patient, you get vital signs, you do a physical exam. Now we're at the arrival of the decision, like, do we think we need to transport you? Do we think you can stay home? Can you go in a car? But like going through that in a stepwise fashion was very difficult because you just didn't realize that was happening in every call before. You just weren't the one that had to do it. And so I would always, you know, get a little more sweaty being first on scene, being like, oh gosh, the fire department's going to pull up any second. Have we haven't done anything yet. We're like trying to get things done. And what do you guys like to see from the crews when they arrive first on scene?
I think it's a mutual thing. Like, how would I want this to go? How would I want people to treat me? And I typically kind of refer to whoever's on scene first. That's essentially their call. Like we can influence that call. We can help out. But whoever's second in, whoever that is, their attitude should be like, hey, how can we help? Right. And helping might be staying out of the way for a moment while we kind of get organized. And so I think a lot of that is communication. A lot of our issues are always communication based, right? So as you notice that another crew come in, it might be just a quick hand wave like, hey guys, see that you're here. I acknowledge you. I'll be with you in a minute. Like I'm right in the middle of something, right? And so I think that goes a long way. But I think it's just a lot of it's attitude and just like, hey, we're all here to help. We all should have the same mission. Right. So what is it I can do that's the most productive?
Right.
I remember a call one time where scene first, and the guy that was there was always, whenever we would be on scene, he'd come in and, you know, rolling the eyes and looking, doing all that stuff. Well, it's their turn now, and it's a cardiac arrest, and they were freaking out because they were on scene first, and they were so glad to see us.
Yeah. So thank you. There's more hands.
Yeah, you know, it's like just work together, and whoever's on scene first, like you said, whoever comes in second, hey, what can I do to help? And check the egos at the door.
Yeah.
How many times have you seen the second in, whoever that happens to be, attempt to take command of the call, and that actually ends up being deleterious? That actually ends up resulting in harm because they've negatively affected rapport with the patient, or there was something that had some, you know, diagnostic momentum that ended up getting missed, overlooked, etc., because this other person swooped in and completely changed the trajectory. How many times have you guys seen anything like that?
I used to have that on the regular because there's one individual that always show up and take over the scene every time.
Yeah.
And he would always apologize. I think he was just always amped up with any emergency that happened. And it could be a simple call. It'd be a nosebleed or something like that. And he would insert himself between me and the patient when I'm talking to him. And every time, like, hey, man, I'm really sorry I did that. I'm like, well, if you're really sorry, stop doing it. Right?
Box out.
Yeah.
Teach the crew to box out. So you got 4 guys around, and they're trying to get in there, and you're boxing them out.
Yeah, and you're like, dude, you just totally disrupted our whole flow here.
Or they're
You
asking
slowed
a
everything
question
down.
you asked 5 minutes ago, and
Yeah.
Asked and answered.
What's interesting to me, though, I think people with some experience that have experienced egos for a period of time and all that, they realize when people do that, it's because they're so uncomfortable. They're not comfortable with the situation. They feel insecure maybe in their own care. And so they feel like they got to take over, right? And it's a lot to trust somebody else to do that. You're not the only paramedic in the world, right? We're all a team. We should be. Let's work as a team.
yeah. Yeah, and when you have paramedic students often enough, too, you get in that habit of letting them kind of do their thing without stepping all over them and just jumping in there when things are going too slow. And, yeah, you have to be comfortable as a paramedic to be able to step back, I think, and let other people do their job, you know.
Well, I think some things like when you have a big incident, when I was working on the AMS, have a big incident, you have multiple patients. Hey, tell me where my patient is, I'll get out of here. You know, I didn't want to hang around. I didn't want to get any closer. Just give me my patient and I'm gone. And you just come to that realization, like, you know, we're all in, like I said, all in this
What's
together.
my
Get
role?
your patient, what's my role? You'd be a lot better get in and get out than hang around.
Yeah.
Mess things up.
Yeah.
It's more hassle than you want anyway.
Right. And I mean, even in the ER, I see parallels. Like if me and Kosh are seeing, you know, patients as a team on whatever shift it is, if I'm in the room for 5 minutes and then he pops in, I pause, catch him up to speed, kind of where we are, so that he's not starting from ground zero and re-asking all the questions I've already gotten answers from. And maybe that's something that the fire department could do more of. I mean, is like, hey, quick pause. This is the patient. Here's what's going on. And just catch them up to speed, which I think probably happens 99% of the time anyway. But I think maybe that's when the crew wants to jump in, is when they're standing there and they don't know what's going on. No one's giving them a summary. And if you're dealing with a critical patient, you can't stop and pause everything. So I get that too. But we're dealing with patients that are not actively dying most of the time. So it's easy to pause and get the other provider caught up. And so
When
we're
I'm
not
working with a
stepping
new
on toes.
EMT, also I give them this advice. Like, we all want to help. We all want to do something, right? It's an emergency. I got to do something.
Right.
And I tell them, if you experience this with a crew where it seems like they're always jumping in the middle of your action, just give them a job. It
Right.
could be a stupid job, but give them a job.
Right.
Hey, can you check the med cabinet for some meds for me?
Yeah.
At least they're out of your hair for a moment.
Right.
And then think about another stupid job you can give them later.
Right.
Because you're just trying to get a flow going. You're trying to develop good patient rapport. Trying to get a plan together. And if this person's jumping in the middle of it, you're just like, now what?"
Yeah, I'll tell Kosh,
Right.
grab an ultrasound machine, bring it in here. Would you mind? Like, you got to give him something to do.
Yeah.
How
I heard
is
there's
it-
free snacks down the hall, right?
Aaron knows how food motivated I am. If he tells me there's food, I'm gone.
That's
You
right.
got this? Cool. I'm going to go get a snack.
Right.
As the officer, I try to be kind of the gatekeeper, not only for the private ambulance, but also for the family members.
Mhm.
Trying to set up that scene so it runs as smoothly as possible. So sometimes it's getting that family member away from that scene,
Absolutely.
or keeping the ambulance crew or even my crew out of the room until we're needed. More bodies, tend to just clog up more space.
Yeah. I mean,
How
we're
is it-
intimidating when we show up.
How is it with riding in with patients?
That's a good
Just 'cause
question.
The fire medic rode in.
Mm-hmm.
And I remember having riding in and making people mad because I rode in. It's like, well, I'm not here. Wouldn't it be better to have 2 hands back there than? And I'm not riding in because somebody sprained their ankle. I'm riding in because I think something's seriously wrong with this patient. You may need some help. And then there's also a time where I didn't ride in when I probably should have rode in.
Is there rules around that? I don't know.
Sort
That
of.
I don't know if that was actually a rule or if that's just something I always thought had to happen. Or
So for certain types of calls, the expectation is that, and for anyone listening that doesn't understand the topic that we're discussing, the way that our system is set up is fire responds, has EMS capabilities, but does not transport. And so we have a private ambulance company that we have contracted that we also, and when I say we, I'm referring to the medical direction oversight team. So we oversee all the agencies, and for certain types of calls, if we determine that it is a high risk call and that it's better to have more hands, then the expectation is that someone, the paramedic usually from the fire department, will ride in the back of the ambulance along with the crew staffing that ambulance to provide an extra set of hands, more care, so on and so forth. And so for certain types of calls, STEMIs, traumas, stuff like that, the expectation is that someone from the fire department will ride in. If the medic, either from the fire side or from the ambulance side, is uncomfortable or wants the extra help or thinks there needs to be the extra help, then, and guys, correct me if I'm wrong on this because you experience it more than I do, they are encouraged to speak up and say, hey, I think from the ambulance side, hey, I'd love it if you would ride in, or from the fire side, hey, I think I should probably ride in on this. But the reverse is true, more so from the ambulance side, I would say, of, you know what, I got this, I'll be okay, why don't we go ahead and keep you guys, why don't you guys go ahead and clear and go back in service. So it's kind of a give and take. Gentlemen, please expand on that or correct any of that if it was not accurate.
So when I was the fire medic, my rule was if it was going to be a hot or emergent return, I'm riding in. Or if I got a good patient rapport and I don't think that I can transfer that patient rapport for that 5, 10, 15-minute transport, I would continue riding in. Or if I was just interested, I would ask, hey, do you mind if I ride in? I'm really interested on this case. I've never had anyone say, nah.
A lot of it's in your approach.
Mm-hmm.
Yeah. So like I'm writing in, like there's no choice. I'm just going to do this. Like, hey, can I write in?
Right.
Right.
And that's
Like
how
that.
I would do that. I would ask too, but I'm asking, telling you, but I would ask.
Right.
Yeah.
Telling you
Ask
how to
first,
do
right?
it.
At least
But
ask.
is there
Hey, you mind if I ride in? and
Is
see
there a
something?
rule that the paramedic from the ambulance has to attend if the paramedic from the fire department rides in?
There's and I actually, to be honest, don't know the official answer to this question, but my anticipation is if a paramedic on the fire side determines that they should be riding in, whether it's because they ask or because, for whatever reason, then there probably should be another paramedic in the back. And I think part of that mentality is in the back of that ambulance. I mean, that's their house, right? And we are asking a fire rider to join, or that fire rider is, I don't like the connotation, but inviting themselves into the house. And sometimes it's necessary. I think we can all agree that sometimes there's that moment of, no, we need the extra set of hands is going on this one. Whether or not it's the ambulance crew saying, no, I need you on this, or the fire person saying, no, you need me on this. But I think the unofficial understanding is it's their living room, so to speak. And so someone should be someone of equal level of credentialing should probably be there.
Okay. Yeah, that makes sense. I think if someone's concerned enough to write in, then it probably needs to be an ALS provider attending in the back.
Mm-hmm.
And I would say too, just as a aside, I always appreciated it too when the fire department would ask permission before putting a family rider in the front in the circumstances where it was kind of sketchy, or most of the time we agree, like, oh yeah, they're totally fine to ride in the front or whatever. But where it's kind of like, it's 2 a.m. in the morning and this is their, cousin twice removed, and he may or may not have a weapon or something on him. I think it's nice to at least, hey, is it okay if we put this person in the front? Do you want us to tell them they need to find a ride? I always appreciated
Absolutely.
like treating it like our ambulance kind of a thing, as opposed to be like, hey, we threw them in the front and you're like, I gotta wipe down that seat now because I think they shit their pants or something. But
well, and there's that's actually a discussion that's come up recently. because the number of times we've experienced something like, and granted, this is more for any that have worked on the private ambulance side of, your lunchbox is up there, and all of a sudden, the snack that you were intending to have is no longer there because that, these aren't snacks for the patient family.
Right,
This was my food.
Yeah.
I like the amenities
This
here.
is our office, unfortunately, in the front.
There's times too, based on resources, our EMTs are well trained in this area. There's times where they just simply need a pair of hands.
Yeah.
And so I've sent my EMT firefighter in,
Yeah.
and it gives them a little bit more exposure, more experience where I didn't necessarily need to be there. So it doesn't need to be a medic in the back. Not
Right.
necessarily. It's another EMT.
Yeah. Well, and I think there needs to be a little bit of a paradigm shift too on the private ambulance, that the paramedic's going to end up attending more calls. Like, we would get so bent out of shape when you're working with your EMT and you're like, I can't believe my EMT hasn't attended 50% of the calls today. I can't believe I've attended 60 or 70% of these. But that's what the job is. Or even getting out of transports. Like, I can't believe the fire department talked him into going. I can't believe we got to take him by ambulance. But that's medical legally, this is the safest option for all of us, is to have this patient go in by ambulance, and this is the job. And it's going to make your day go by quicker if you're doing more transports. And they have plenty of coverage right now too. So it's, they're not running, it's not the old days where they're running 14 calls in 12 hours. And maybe then I could see it a little bit, but the volume that we see now has shifted my paradigm significantly. Like, it'd be easy to attend every single call as a paramedic and write the report. It's a little bit of a paradigm shift where I think on the private ambulance you're looking to get out of transport. Maybe that was just me back in the day. I'm like, how can we get back to sitting and doing nothing the quickest sometimes?
Right,
and maybe
that's
that's probably burnout to a
Yeah.
degree too.
Yeah.
But I
Absolutely.
think that paradigm still exists, in a lot of people. They're like, how do we get out of this transport? And they're not putting the patient first. And even if the patient's not critical and could drive themselves, this is still liability wise the safest for all of us, is to take this person by
Right.
ambulance
And
to the
patients
hospital.
pick up on that. One of the most validating moments I ever saw, it was interesting, worked with this particular medic, and they were burnt out. They did not want to transport. They can do anything to get out of transporting. But we happened to be downtown with a drunk individual, and they recognized it right away. And they said to this person, they said, "You're a paramedic?" And they said, "Yes." And they said, "Well, then be a paramedic."
Wow.
And I was like, wow, they've only met them for 30 seconds and they picked up on their
Yeah.
resistance to this.
Right.
Like, that is your primary job. That is how
Right.
you earn your income.
Right.
And so, yeah, none of us want to do all the extra stuff.
Right.
I totally get the accumulation and the burnout and all that,
Right.
but that is your primary job.
Right.
And not that this should be the primary influencer in any way, shape, or form, but I think what a lot of out-of-hospital clinicians don't realize is there is no payment for showing up on scene. You only get paid if you transport. And so if all of your calls for a given shift are refusals, whether or not they were appropriate refusals, that's basically time that your company is not getting paid, and potentially that's going to trickle back down to you.
I think I always understood that, and I could have cared less.
That's true.
Like, I don't-
It is what
I'm
it is.
making the same hourly pay regardless of.
Until the ambulance company goes bankrupt.
Yeah.
Yeah.
But it's also, but from a patient-centered perspective,
Yes.
it's the safest thing for the patient. We
Yes.
only have so much information we can glean on scene.
Absolutely.
When we discharge someone from the ER, we usually have an abundance of objective data to say this person's safe to go home. You just don't have that information on scene. You've got vital
Exactly.
signs, a 12 lead, and glucose. And yeah, maybe they look great and their family could drive them, and maybe they shouldn't have called 911 to begin with, or we wouldn't have called 911. But still, the most patient-centered thing to do is to take them by ambulance. They were concerned enough to call, and
Yep.
this is the job.
It's-
And that's a paradigm that I probably didn't have to a healthy amount when I was on the ambulance. Maybe, during periods of burnout that would wax and wane, but I think that's a paradigm that kind of needs to change a little bit, because crews get more burned out by this. Like, I can't believe we transported everybody today.
Mm-hmm.
And if you change it to this is what the job is, as opposed to using it as a friction point, I think you're more happy at the end of the day instead of frustrated. But
I always tell newer EMTs and paramedics, and none of us are going to be perfect at this. I certainly am not. But if you always treat this patient as if it's your family member, you're always going to do the right thing.
Mm-hmm.
You're not going to overtreat. You're not going to undertreat.
Right.
If this was your little grandma or whatever, what would you want done?
Right.
You would want her to be treated with respect. You would want her to receive the best treatment possible.
Right.
And all of
Exactly.
those things.
And when I have a patient who I tell, I come back in the room after I've gotten a whole bunch of labs, imaging, CT scan, whatever, and I'm able to tell them, look, nothing's wrong. A lot of the time, even before that, sometimes they'll say, I feel really stupid being here. And my usual response to them is, it's not your job to know what's going on with your body. Aside from the fact of, there's those people that will always say, I know my body. I find that that's usually used only to prove the exact opposite. But the response that I give them is, it's not your job to know whether or not something's an emergency. That's my job, right? And that's not something that I can determine with you sitting at home not doing anything, right? The only way for us to determine whether or not there is an emergency happening is for you to come in and for us to evaluate it. And so if the most important thing that I can do today is reassure you that you're okay, reassure you that nothing is injured, infected, whatever, then I've done my job.
Yeah, I mean, most of what we do is negative workups to prove you're not dying and you're safe to go home. It's when one of our tests is positive that it's a problem, and it's usually because it's something emergent. Our tests are sensitive for emergent things, not for non-emergent things. So when they're positive, it's,
And we have a very different mindset compared to other specialties in the House of Medicine. Our approach is, prove to me that you're not sick. Right? Prove to me that it's safe for me to send you home, as opposed to a lot of the times for these other subspecialties or whatever, prove to me that you are sick. Prove to me that you actually need my help. Right? And that's nothing against them, because it's very appropriate. You wouldn't want to send an acute cholecystitis to an ophthalmologist, right? And similarly, you wouldn't want to send a retinal detachment to a general surgeon, right? You want to have the right thing going to the right person, but our approach in emergency medicine is very different, because everyone has an emergency until proven otherwise.
Well, and they're a self-selected population that is, if they're going to have the problem, it's going to be one of these patients. Whether they called 911 or drove themselves to the ER, they're selecting in as high risk to have something emergent going on. So we have the burden to prove that they don't or that they do.
The pretest probability is high. And it's our job to do the test to reduce that chance, and then have the post-test probability of them either being okay or actually having an acute medical condition or traumatic or whatever condition become what it is.
Right.
I never got a subpoena for taking somebody to the hospital against their will. Never. And
as long as you document it well.
You document it well. Yeah.
That's where the key.
You got to document it well, but where you can get in trouble is leaving them there. So
Yeah.
it's better to err on taking them to the hospital. I know that, I was acute. We don't kidnap patients. Well, you don't understand what the term kidnapping means.
Right.
If you're erring on this in the best interest of the patient, you're technically not kidnapping them.
Right.
And that goes going back to that refusal aspect of things, is the patient with who initially had an altered mental status, initially didn't have capacity, but then you did something, either giving them oxygen or Narcan or glucose, and now all of a sudden they're of clear mental state, right? Because there was an emergent condition. They didn't have capacity. You did something and you restored their capacity. Does that person now have the ability to refuse?
Well, we did a whole bunch with D50. I don't know how many we did D50, give them D50, and they wake up. And now when I'm looking back and what I know now, hindsight, they probably should have gone to the hospital.
Because they could drop again.
They were hypoglycemic. We made them hyperglycemic. We all high-fived each other. Here's sign here, and we left.
Mm-hmm.
Yeah, eat this high carb, high sugar sandwich.
Exactly.
I made you a peanut butter sandwich from the stuff in your kitchen. I hope that was okay.
Yeah.
You need some high in protein. The things we used to say and do, and now that
I always used to say, "Here's some complex carbohydrates." I didn't even know what they were
Here's
at the
some
time,
white
but I was like,
bread.
"Here's
I heard
complex
somebody else say it.
carbohydrates."
Sounds good.
But yeah, so now your patient's either headed towards DKA or rebound hypoglycemia, and
yeah.
right, or that patient you gave Narcan to. When the half life of Narcan is shorter than the half life of opioids, so when the Narcan leaves their system and they are now unresponsive because of respiratory arrest again.
Well, that's why you only give them a quarter.
Yeah, you don't wake
You
them
just
up.
give them up that the respirations come up. You don't slam them with
That's the
two
goal.
because I've seen it happen.
You don't
Titrate
want
to
them
effect.
capable
I'm
of
not going to the
refusing.
hospital.
Yeah.
Right.
Yeah, it's like no. So you just give them a little bit.
Yeah.
Right.
Pulse ox comes up. It's like all right.
Now
Well,
we
and
don't
the
have to have an
other
argument.
the other advantage to that, it's not just just high enough that they're breathing on their own and can't refuse. There's another piece to that, and that piece is it's also harmful to the patient to put them into precipitated withdrawal.
Yeah.
So not completely reversing them is actually a patient-oriented treatment.
Yeah.
Right? It's not just, I don't want them to throw up in the back of my ambulance, which is a fair thing to want, right? No one's arguing against that. But also, precipitated withdrawal is very, very uncomfortable. You're basically taking them from that slow state of maybe I'm a little twitchy or, I'm a little antsy or now I've got goosebumps or whatever to I'm nauseated, I'm throwing up, I have diarrhea, I have like all these other things.
Right. Complicated.
And making that pendulum swing very rapidly, which is a shock to the system, right?
Mhm.
Which is going to cause other issues, anxiety, whatever. And so it's actually, it had an unintended beneficial effect doing it that way.
Well, the way the protocols were, and I'm sure they've changed, was you gave them 2 milligrams. And if you talked about giving them a quarter, they go, no, you got to give them 2. Or
Yeah.
you give them enough D50 to wake them up. No, you have to give them the whole amp.
thing,
It's like,
yeah.
well, common sense. Then just, try to fix the
And-
problem, but don't make it worse.
And now we don't do D50 anymore.
No
Right.
way. What do you do now?
D10.
D10.
D10,
Drip.
and that makes more sense. Yeah, it makes
Because
a
there's
lot more
data that shows that what we would give D50 and we would fix the hypoglycemia, but patients would have a much harder time regaining control of their blood sugar afterwards.
sense. Yeah. Well, I think they should come out with instead of a glucometer, I don't know, insulin monitor, where you're checking their insulin levels more than you're worried about their glucose levels. I mean, maybe we should invent that. And,
I think that's a
Okay.
harder
Yeah.
level to check, but
Never
It
I think
is.
you can check
Yeah, it's
insulin
gotta be.
levels, but
It's a specific molecule that allows you to evaluate that level, and that's a molecule that you actually can't test for if the patient is receiving insulin. Because it's a piece of the molecule that's cut off in the manufacturing process in the body, shall we say? I'll go into a very short digression. So the insulin protein is folded in a certain way. So you have this one long chain, and then it gets folded over. There's obviously a little bit more to it than this, but it gets folded over into this U shape. And the end of the U is cut off. So now you have something that looks like railroad tracks, kind of. And the blood test looks for that U component. It's actually C at that point, called the C peptide, because this curve looks like a C. So that's what we test for, to see if someone's got a lot of their own insulin, or if they're actually making insulin, or so on and so forth. And so it's tough to test for that in it's a protein test, which means you need a specific analysis for it.
you're way too smart. You must have went to
That's why he
medical
makes a
school
good
or
choice.
something. Also a really good actor too. That role play earlier, I was in the patient's dirty ass apartment and it was 2 a.m. and I was like, how are we getting out of this?
I don't want to be here. I don't feel safe.
We're having to call medical control now. I just want to go back to sleep.
I could play that role too.
Well, I want to respect your guys' time. We're at 2 hours, so I want to kind of wrap things up. Did anybody have anything else they wanted to say that we didn't get to today, or anything that you came wanting to talk about?
I just say, for you guys, it's going to be over quicker than you think. It'll be over, so get ready for it. It could be tomorrow, but I mean, realistically, 5-10 years, maybe what you guys got left. Get ready for it and start looking beyond this. And retirement's great. It really is. I'm having the best time of my life right now. So look ahead.
I like it.
Cool. Well, thanks, guys. We'll end it there.
Thanks for having us.
Yep. Thanks
you.
for the invite.
Yeah, absolutely.